Welcome back to the deep dive. Today, we're tackling a really key topic, one that pops up in exams like the MSRA and in acute clinical settings, Bell's palsy. We've got a set of detailed revision notes here, and our mission, really, is to turn these notes into a high-yield chat, something easy to digest, focusing on what you absolutely need to know for quick recall.
Exactly. We're going straight from these notes covering the definition, what causes it, the signs, management, basically everything you'd need to feel confident about Bell's palsy based just on this material.
Perfect. Friendly, focused, getting those key facts locked in. Okay, let's unpack this. So, starting right at the top, the definition. The notes say Bell's palsy is a sudden unilateral facial paralysis.
One-sided. And it's down to inflammation or compression of the facial nerve. That's cranial nerve 7.
And they give a couple of other names too, right? Idiopathic facial paralysis.
Yeah, IFP, or you often just hear it called a lower motor neuron facial palsy. And the core thing is that weakness or paralysis of the facial muscles, but just on one side.
And understanding that nerve, seeing the 7, is key to understanding the symptoms. The notes have a useful way to remember what it does.
They do. It's a great little memory aid. Face, ear, taste, tear.
Okay, break that down for us.
Sure. Face is pretty straightforward, the muscles for facial expressions. Smiling, frowning, raising your eyebrows, all that.
Got it.
Ear refers to a tiny muscle in the middle ear, the stapedius. It helps control how you perceive loud sounds.
Right.
Taste is for, well, taste, specifically the front two-thirds of your tongue.
Okay.
And tear covers tear production via the lacrimal glands and also some salivary glands. So knowing those really helps make sense of the different symptoms someone might have.
Absolutely. It's not just the face drooping. You might get changes in taste or dry eye. Makes sense. And the notes emphasize the onset. It's sudden, usually within, what, 72 hours?
Yeah, typically unilateral and acute, hitting within 72 hours.
So face, ear, taste, tear muscles, sound sensitivity, taste, and tear saliva. Good quick check. The notes also dip into the anatomy briefly. We don't need every detail, but what's the sort of crucial bit about the nerve's journey that explains why this happens?
Well, the nerve travels through this bony tunnel in the skull called the facial canal. It starts at the brainstem, goes through there giving off branches, before it eventually exits near the jaw. And the notes point this out because that facial canal is really narrow. It's a tight space.
Ah, okay, so when the nerve gets inflamed.
Exactly. It swells up, but there's nowhere for it to go inside that bony canal. So it gets compressed.
Like squashing something in a pipe. That makes sense. So inflammation leads to compression in that narrow canal. Okay, so what actually causes that inflammation? The notes say it's often idiopathic.
Right, meaning we often don't pinpoint a specific cause, but the primary suspect, the one the notes really highlight, is viral infection.
Any particular virus?
Herpes simplex virus, type 1 HSV1, the one that usually causes cold sores. That's thought to be a major trigger.
Interesting. The cold sore virus. Are other viruses mentioned in the notes?
Yeah, they list a few others. Herpes zoster, that's the shingles virus, which causes Ramsay-Hunt syndrome, a related condition. Also HIV, Epstein-Barr virus, CMV, and Lyme disease is mentioned too, though that's bacterial.
Okay. And beyond infections, the notes seem to list quite a few other potential causes.
They do. They categorize them like iatrogenic, meaning caused by medical procedures, maybe local anesthetic or certain drugs like linezolid, neurological links like Guillain-Barré or diabetic nerve issues, MS, trauma skull fractures, even forceps during birth, tumors, neoplastic causes near the nerve path. Autoimmune conditions are on the list too, sarcoidosis, Sjogren's, rheumatoid arthritis, and pregnancy, especially later on, or with things like hypertension or eclampsia.
Wow, that's quite a list. It shows you really need to think broadly if the picture isn't quite typical Bell's. And the notes mention specific things for kids?
Yes, for children, they single out Lyme disease and middle ear infections as possibilities to consider.
And what about both sides of the face being affected? That's much rarer, isn't it?
Much rarer. The notes list causes for bilateral palsy, sarcoidosis, GBS, Lyme again, tumors like bilateral acoustic neuromas, and very occasionally actual bilateral Bell's palsy.
Okay, this brings us to something really crucial the notes emphasize. When you see facial weakness, how do you tell if it's Bell's palsy, a lower motor neuron issue, versus something like a stroke, which is upper motor neuron?
This is absolutely key. It comes down to the forehead.
The forehead. How so?
An upper motor neuron lesion, like a stroke affecting the brain pathways, usually spares the forehead muscles. So the person can still wrinkle their forehead or raise their eyebrow on the affected side, even if the lower face is weak.
Ah, because the forehead muscles get nerve supply from both sides of the brain, right?
Exactly. But a lower motor neuron lesion, like Bell's palsy, affects the nerve after those bilateral connections. So the entire side of the face is affected equally. The person cannot wrinkle their forehead or raise their eyebrow on that side.
That's such a vital clinical sign. So, quick check. Can they wrinkle their forehead? Yes. Think UMN? Maybe stroke? No. Think LMN, like Bell's palsy, though the notes do caution some things can cause both.
Yeah, it's not foolproof, but it's your first most critical differentiator. Look at the forehead.
Okay, so who tends to get Bell's palsy? What risk factors do the notes highlight?
The main ones listed are having had a recent viral illness, like a cold or upper respiratory infection. Pregnancy is a big one, especially the third trimester. Diabetes, having a family history of it. And stress is also mentioned.
Right, and the notes seem to really flag pregnancy and diabetes as significant risk factors.
They do, yeah.
So let's recap the mechanism, the pathophysiology. How does it actually happen? Inflammation.
Yes, inflammation starts in the facial nerve, maybe triggered by that HSV1 reactivation, for example. This makes the nerve swell up.
And because it's in that narrow facial canal,
It gets compressed. The swelling physically squeezes the nerve, and that compression messes up the nerve signals. It can block or slow down the electrical messages going to the muscles and glands.
leading to the weakness, the paralysis, the drooping face. Simple chain of events. Trigger inflammation, swelling, compression and canal, nerve dysfunction. Symptoms.
Right, okay, so someone presents with this unilateral facial weakness. Bell's is common, but what else must be on your differential diagnosis list, according to these notes? What do you need to rule out?
Top of the list is stroke, and again, that UMN versus LMN forehead check is your immediate clinical tool. Lyme disease is important, especially if there's any history suggesting tick exposure. Ramsay-Hunt syndrome, that's the herpes zoster one, often more painful, maybe with blisters near the ear. And then you'd consider those other rarer causes we listed if the picture seems unusual.
Okay, so stroke, Lyme, Ramsay-Hunt are the big three differentials to actively consider. What about how common it is? Any numbers in the notes?
Yeah, they give UK figures, roughly 20 to 30 cases per 100,000 people per year.
And the age group.
It can occur at any age, but the notes say it's most common between 15 and 45, though most cases generally fall between 15 and 60. Right. Let's paint the picture now, the clinical presentation. What are you actually seeing?
Well, the hallmark is that sudden one-sided facial weakness or paralysis. Specifically, the notes detail things like difficulty closing the eye properly on that side. You'll see drooping at the corner of the mouth, maybe the eyelid too. Often, the nasolabial fold that creased from nose to mouth corner looks flattened or lost on the affected side. And linking back to face, ear, taste, tear, maybe altered taste on the front of the tongue. Some people get hyperacusis sound seeming too loud, possibly some pain behind the ear.
And crucially, that LMN sign again.
Absolutely. The inability to raise the eyebrow or wrinkle the forehead on that affected side, that's a key part of the picture.
And practically speaking, that eye issue is significant.
Very. Not being able to close the eye leads to exposure, dryness, a real risk. And functionally, they might struggle to puff their cheeks, whistle, show teeth on that side, smile symmetrically. The notes also mention synkinesis, these odd involuntary movements, like the eye twitching when trying to smile. But that tends to develop later, if it happens, during recovery, not usually there right at the start.
And there's a way to grade how bad it is.
Yes, the House-Brackman scale, HBS, grade 1 is normal, grade 6 is total paralysis, no movement. It helps track the severity. So the diagnosis is really clinical. Rapid onset, unilateral, definitely LMN, forehead involved, and ruling out those key mimics like stroke. Then you use the HBS to grade it. Remember to ask about risk factors.
Okay, diagnosis is clinical. Do you generally need lots of tests?
Usually not for straightforward Bells, according to the notes. The diagnosis is clinical. Tests are more about ruling out other things if the story isn't quite right.
Like if you suspect Lyme disease.
Exactly. The notes suggest blood test serology for Lyme, maybe herpes viruses, zoster, often needing paired samples over time. For kids, they specifically mention checking blood pressure because of rare links to things like aortic coarctation. There are other tests mentioned like Schirmer's for tear production, stapedial reflex testing, nerve conduction studies like ENOG or EMG, but the notes say these are rarely done for typical Bells, maybe more for severe cases or research, to assess nerve damage depth.
Got it. Tests are more for ruling out mimics or assessing severity in complex cases, so the diagnosis is made. What's the management plan according to these notes? What do you do?
Number one priority, eye care. This is stressed heavily in the notes because they can't blink or close the eye fully. It needs protection. So that means frequent lubricating eye drops, artificial tears during the day,
And at night?
thicker lubricating ointment at night, and crucially, taping the eyelids shut. The notes are clear. This is essential non-prescribing management to prevent corneal drying, ulceration, serious problem.
Protect the eye. Makes sense. What about medications?
Corticosteroids are the mainstay. Prednisolone is typical. The key, emphasized in the notes, is starting them early, ideally within 72 hours of onset. The aim is to reduce that nerve inflammation and swelling quickly.
Okay, steroids within 72 hours. What about antivirals?
The notes reflect a bit of debate there. Some guidelines might recommend them, especially for severe cases like grade 5 or 6, often alongside steroids. But the notes indicate they aren't always routinely recommended, as the evidence isn't as strong as for steroids alone. Physiotherapy is also mentioned. Facial exercises, massage. The notes say this may be beneficial for some patients.
And when would you need to refer someone to a specialist?
Referrals are needed if the presentation is atypical, if there's absolutely no improvement after a few weeks, or if problems like synkinesis develop later. Surgery is mentioned too, nerve decompression surgery, but only considered in very specific, severe cases that don't respond to medication, meeting certain criteria based on movement and nerve tests. Reconstructive surgery is a later option for permanent issues.
And for kids, the approach is
More thorough investigation usually,
Mhm.
including imaging, to rule out those specific childhood causes.
okay. Now, the question everyone wants answered. Prognosis. What's the outlook? How likely are people to get better?
Generally, the outlook is pretty good. The notes highlight that most people recover spontaneously, often within 3 or 4 months, even without any treatment sometimes.
That's quite positive. Are there stats in the notes?
Yes, they quote figures like around 85% showing some improvement within 3 weeks, and about 71% achieving a full, complete recovery eventually.
Okay, so most do well, but not everyone gets back to 100%.
No, not everyone. The notes state about 16% might have noticeable long-term effects, or sequelae, and maybe 5% have more severe lasting complications. And the notes list factors that suggest a poorer outcome. Things like having a complete paralysis right from the start, grade 6, showing 0 signs of recovery by 3 weeks, being older, over 60, having severe pain, if it's actually Ramsay-Hunt syndrome, or having underlying conditions like diabetes, hypertension, or being pregnant.
So even if the main weakness improves, some might be left with things like that synkinesis.
Exactly. Synkinesis,
Yeah.
or that crocodile tears thing, gustatory lacrimation, where you tear up when eating. These are signs of nerve fibers regrowing imperfectly. The notes mention treatments like botulinum toxin injections can sometimes help manage synkinesis symptoms.
And finally, summing up the potential complications, the long-term problems noted.
The main ones listed are incomplete recovery, leaving some facial weakness or asymmetry; synkinesis, those unwanted linked movements; eye problems, chronic dry eye; corneal issues from exposure.
And the impact isn't just physical?
No, the notes explicitly mention the psychological impact, potential depression, issues with self-image, social anxiety related to the facial changes. It's a significant potential complication, and rarely chronic facial pain or ongoing motor issues.
That's a really thorough overview from those notes. Let's try and crystallize the absolute must-know points for revision.
Okay, Bell's palsy. Sudden unilateral lower motor neuron facial palsy, likely viral trigger, often HSV1. Think pregnancy, diabetes as key risk factors mentioned in the notes.
Clinically, the crunch point is checking that forehead. Can't wrinkle it. Think LMN, Bell's is high on the list, can wrinkle it. Think UMN, Stroop is a major concern.
Absolutely. Management essentials from the notes: urgent steroids within 72 hours ideally, and meticulous eye care drops, ointment, taping.
Prognosis. Generally good. Most recover well within months, but watch out for those poor prognostic signs: complete palsy, no early recovery, older age, and be aware of potential long-term things like synkinesis or eye issues.
Right. So having this framework means when you encounter acute facial droop, you can assess quickly, think about differentials, start the key initial management steps, and have a good idea of the likely path forward based on these notes. You know, this raises an interesting point. The notes mention the psychological impact. Given how visible Bell's palsy is, how might clinicians best support patients with that aspect, beyond just the nerve recovery? It's something important to think about, that holistic care angle.
That's a great point to ponder. So there we have it, our deep dive into Bell's palsy. distilled from these MSRA revision notes.
Yeah, hopefully breaking it down like this helps it stick, whether you're revising or just refreshing your knowledge. Gives you that confidence.
And if you are revising for the MSRA, these notes came from passthemsra.com. Definitely worth checking out for more high-yield content.
And don't forget freemsra.com for loads of excellent free revision resources too.
Thanks so much for joining us on the deep dive. We'll catch you next time.